Continuing with the topics, I'm going to talk about cytopenias in lupus. Above all, I'll try to answer the question of when it's due to disease activity and when it's a side effect of medication. This is the outline I'm going to follow. I'll start with a brief introduction, then I'll talk about cytopenias in lupus. After that, I'll differentiate between when it's identified as disease activity and when it's drug toxicity. I'll go on to discuss diagnostic tools. Afterwards, I'll explain a bit about the management of cytopenias in lupus and finish with the conclusions. Well, as you already know, lupus is a chronic inflammatory disease of autoimmune origin that presents with heterogeneous clinical manifestations, but with a common denominator, which is the presence of autoantibodies and a hyperactivation of the immune system. As for cytopenias, they are a relatively common manifestation in lupus. They are present in about 20–30% of patients, and the causes are varied, ranging from disease activity to organ damage, drug toxicity, myelodysplastic syndrome, and even, although less frequently, there are also serious complications such as macrophage activation syndrome or catastrophic APS, which can present with cytopenias. Early detection and management are important, especially in terms of the patient's prognosis. As you already know, both thrombocytopenia and leukopenia score 1 point on the scale, SLE-I2K. And now moving on to hematological manifestations. We begin with anemia. It is defined by blood hemoglobin levels of less than 12 grams per deciliter in women and less than 14 grams per deciliter in men. The most common type of anemia in lupus is anemia of chronic disease, which is normocytic and normochromic. And what we would expect to find in lab tests is low serum iron, along with low transferrin and high ferritin. However, the most characteristic anemia in lupus, although less common, is autoimmune hemolytic anemia, in which we would expect to find elevated indirect bilirubin and LDH in lab tests, an increase in reticulocytes, and a decrease in haptoglobin. The laboratory tests we use to diagnose this are the direct Coombs test and the peripheral blood smear, where we would see schistocytes. Continuing with the hematological manifestations, we have leukopenia, which is one of the most common manifestations, present in nearly half of patients, and is defined by blood counts of less than 4,000 per microliter. This can also be immune-mediated, which would be related to disease activity, or like the previous one, secondary to drug toxicity, infections, or other cytopenias such as lymphopenia or neutropenia. Moving on to thrombocytopenia, it is defined as a platelet count of less than 150,000 per microliter of blood, and is present in 10–30% of patients. In most cases, it tends to be mild. It can also be immune-mediated, such as primary autoimmune thrombocytopenia, caused by antibody-mediated platelet destruction, or that associated with antiphospholipid syndrome. Additionally, it can also be secondary to medications or related to serious complications such as macrophage activation syndrome, or bone marrow neoplastic infiltration, or secondary to infections, as with the others. As for lymphadenopathy, it is also related to lupus activity and physical examination. What we would expect to find are enlarged lymph nodes that are soft and painless to the touch. The most common areas would be the inguinal, axillary, and cervical regions. And here, if we perform a biopsy, what we would expect to find is reactive hyperplasia and varying degrees of coagulative necrosis. It is very important to carry out a proper differential diagnosis, especially with infections and neoplastic processes. Now then, is it a flare-up or a side effect? We define a disease flare as a worsening of symptoms or the appearance of new symptoms related to disease activity. So, when a patient presents with cytopenias and leads us to think it might be a flare-up, we would also expect to find some other associated symptom, such as fatigue, fever, arthritis, the appearance of new skin lesions or worsening of existing ones, constitutional symptoms, etc. In addition, we would also expect to find some laboratory findings, such as an increase in antibodies, decreased complement levels, impaired kidney function in the form of proteinuria, elevated creatinine, pyuria without a urinary tract infection, or data suggestive of hemolysis, which I mentioned earlier. Now, if we only find cytopenias, this might lead us to think more in terms of drug toxicity. So the first thing to do here would be a thorough review of the patient's medication history, looking at the drugs they have been using, the duration of the treatments, dosages and regimens, and above all, any recent changes in medication. Among the drugs we use, those most commonly associated are corticosteroids, which, although they can initially cause leukocytosis, over time may lead to leukopenia or thrombocytopenia. In addition, azathioprine can cause myelosuppression, especially in patients who have a deficiency in thiopurine methyltransferase or the NUDT15 enzyme, which I will explain a bit more about later. Methotrexate as well. Patients we usually see with methotrexate-induced myelosuppression in the clinic are patients elderly who may make dosing errors and take more than they should, or patients with renal insufficiency. Other drugs would include cyclophosphamide or mycophenolate. Now then, a patient comes to the clinic with cytopenias. The first thing we should do here is take a targeted medical history, asking about systemic symptoms, fever, fatigue, weight loss, and cardiac, pulmonary, or neurological signs. Also a physical examination checking for new skin lesions, arthritis, peripheral edema, skin pallor, ecchymosis, or lymphadenopathy. And afterwards, we would proceed with laboratory tests. We would request a complete blood count to assess the pattern of cytopenias, liver function, autoimmunity markers, as well as acute phase reactants, hemolysis parameters, which I've also mentioned earlier, and serologies for parvovirus B19, Epstein-Barr virus, and cytomegalovirus. Hepatitis B, T-cell viruses, syphilis. And I'm showing this slide because I believe it's a diagnosis we should also keep in mind. Leishmaniasis, especially in patients from the Mediterranean basin who present with cytopenias, fever, and lymphadenopathy. And here I'm showing images of a patient who was hospitalized, immunosuppressed, and developed leishmaniasis with a 15 centimeter splenomegaly, which you can see here. A few brief notes on the diagnosis of leishmaniasis. It is usually diagnosed by performing a biopsy of the affected tissue, whether it be skin, bone marrow, or spleen, and a Giemsa stain is used to observe a mastigotes. The parasite can also be isolated using more specific culture media. A PCR can also be performed on the obtained sample. To detect antibodies, immunological techniques such as ELISA or indirect immunofluorescence can be used. And then we can also rely on imaging tests such as ultrasound and CT scans. Here are a few brief points to keep in mind, especially regarding the toxicity of azathioprine, which involves the levels of thiopurine methyltransferase, a key cytosolic enzyme in purine metabolism. Its main function is to inactivate toxic metabolites, such as 6-thioguanine. And another enzyme is the NUT15 enzyme, which also inactivates toxic metabolites through phosphorylation. However, it is true that for this latter enzyme, we still do not have laboratory or genetic tests available to quantify it in clinical practice. And well, as a point of interest, the activity of these two enzymes varies between individuals due to genetic polymorphisms, and it is known that in individuals of European and African descent, thiopurine methyltransferase deficiency is more common. Whereas in Asian or Hispanic patients, NUT15 enzyme deficiency is more frequent. Now then, when would a bone marrow aspiration and/or biopsy be indicated? Primarily to rule out myelosuppression caused by medications versus neoplastic infiltration of the marrow, hemophagocytic syndrome with lupus, or visceral leishmaniasis. A few brief notes on the management of cytopenias in lupus. If we suspect a drug, it should be temporarily or permanently discontinued if possible. And then, if the cytopenia has been well tolerated and not too severe, we could consider a controlled reintroduction, which will also help us confirm causality. I would also like to make a special mention of azathioprine monitoring. When starting this drug, a complete blood count should be performed weekly or bi-weekly during the first 2 months. And if cytopenias occur and the decision is made to continue the drug, the dose should be reduced by half and then checked again after 2 weeks with a blood count. And well, if it's due to lupus activity, a flare-up, then obviously the flare should be treated. I also think patient education is very important in terms of preventing toxicity. That means explaining the toxicity of the drugs we use, the warning signs and symptoms such as extreme fatigue, bruising, and recurrent infections, and also conducting monitoring of kidney function, liver function, and blood counts during consultations. And finally, cytopenias can result either from disease activity or from drug toxicity, and in many cases, it's difficult to tell them apart. The medication history and timeline can also give us some clues, and the clinical manifestations along with laboratory findings can help us differentiate. On the other hand, regular monitoring and patient education, I also believe, are key when it comes to preventing toxicity, and of course, management should be individualized by monitoring disease activity along with patient safety and prioritizing quality of life. And well, that would be all. Thank you very much.